Welcome to the session, The Whys and Hows of Hospital at Home, a North Texas Medical Center case study. In this engaging panel discussion, healthcare leaders share the key pillars to expertly implement hospital at home, with insights from Tom Sledge, CEO of North Texas Medical Center, on his organization's experience. Before we begin, we'd like to thank the sponsor of today's session, Community Hospital Corporation. Thank you, and please enjoy the session. Hello, everyone. I'm Maria Castellucci, Deputy Editor of Custom Content at Modern Healthcare, and I'm thrilled today to be moderating this panel discussion on hospital at home, including how to implement it successfully and best practices. Joining me today in this discussion is Jim Kendrick, President and CEO of Community Hospital Corporation, Brian Doerr, Senior Vice President of Information Technology and Security and Privacy Officer at CHC, and Tom Sledge, CEO of North Texas Medical Center. Thank you all so much for being here today.
Thank you.
Thank you.
Jim, let's start with you to set the scene. Why did CHC decide to bring hospital at home services to its client hospitals?
We work with rural hospitals all across the country, and of course, rural hospitals are struggling. A lot of hospitals are struggling across the country with the large percentage of them that are actually losing money. That percentage of hospitals that are losing money is disproportionately aligned in the rural markets just because of the dynamics of a rural market and the finances of a rural market. And we realized that we're going to have to discover new ways to deliver care, creative ways to package things. And the hospital at home model is a model where we've seen the data that shows the quality is as good, if not better, and the cost is lower, and the patient satisfaction of it is actually higher. So all of those things are drivers toward, hey, this is something we need to make sure we're positioning ourselves to be able to provide for the rural communities. It's very complicated. When you start to move forward with this, there's a lot of dynamics that have to be done. You have to get a lot of buy-in because people have a misperception of what hospital at home is. A lot of times they simply say, "Isn't that just home health?" It's so much more than that. And our ability to offer this in the rural markets, we believe, will be a differentiator. And some rural markets being able to maintain care that they would not be able to provide, and also maintain a connection with their community in ways that will allow them to stay in their market and not have to travel for care. Sometimes the level of care that they're needing can be provided at the local hospital, but also sometimes the ability to get to the hospital is more difficult for them, and the hospital at home gives that opportunity to be cared for at home.
Great. And Jim, can you give us a little bit more details about the service? So, what was involved with creating a hospital home service that would work for community hospitals?
So the first piece that we wanted to do is make sure we had the right platform to be able to deliver the care effectively, make sure we're getting all the quality things focused on and addressed so that the patient is getting the absolute best possible care. So we did a lot of research in trying to find the right partner. We wanted the right platform to be able to deliver the care. We searched a lot of different providers, and we ended up working with Resilient. And Resilient and our company came together to form a joint venture, and we call it Resilient Community. And that joint venture is what we package to say, how are we going to take this out as an offering? And North Texas is one of our managed facilities, one of our leased facilities. And we took it to them and said, all right, we need a successful program, and we want you guys to be our pilot so that we can work through this, make sure that it's a good delivery from a quality perspective, it's a good different from patient experience, and it's also something that can be profitable. It has to be able to sustain itself. So North Texas was our pilot, and we've gone through all of the steps necessary to make that work. But it's important that you have the right tools, and then you have someone who knows how to get you through the legal process with both regulatory, both at the federal and the state level, to make sure you're positioned to provide that care and be compensated for providing that care.
Yeah, and that's a great transition to Tom. So, Tom, as CEO of North Texas Medical Center, can you talk about what inspired your organization to be part of this pilot?
For us, it was just another avenue for us to meet our mission of providing exceptional patient centered care and expanding the healthcare services we offer to the community. For the appropriate patient, hospital home can be a safe, high quality, and cost effective alternative to traditional hospitalization.
So, can you talk a little bit about your market and kind of the patients that you're serving and how hospital of home works for your organization?
Sure. Our patient volumes have grown considerably over the last 5 years. So, hospital at home allows us to expand that growth with less strain on resources while providing the patients the same outcomes as if they were in the hospital. Our service area makes hospital at home a logical option for us. The market we serve includes Olive Cook County and ranges north from Denton County and into Montague, Grayson, and even southern Oklahoma.
Brian, I would love for you to talk about the technology aspect behind this. So, for our leaders listening today who want to build a hospital at home program, can you
Sure.
talk about the technology and resource requirements that they would need to implement hospital at home services specifically for rural and community hospitals?
Rural and community hospitals have limited resources, and a project like this is a significant technological lift, right? We have telecom challenges, not only at the facility, we have broadband challenges. We also have cellular challenges because these are rural markets. So we need a provider that can give us multiple different avenues to connect the platform with the facility and with the providers, right? We also need remote access into the EHR. So we need to work with the facilities to make sure providers have the ability to work wherever they're at, as well as if we're registering patients remotely or we're connecting to billing activities, we need to be able to do that wherever we're at. So we need to make sure that we have all of that. And then the last thing I think that facilities need to look at is a process around data integration, right? So we're utilizing a lot of different providers, a lot of different systems. And one of the critical components of that is making sure that the right information is at the right place at the right time, not only to provide care to patients, but then to facilitate the billing activities that have to happen afterwards. So we work with our partner Braziliant on that. We work with a facility like North Texas as our pilot, and then our technology providers to make sure that all of that data integration, all of the connectivity is there so that we can make sure that patients are taken care of appropriately, effectively, and timely.
Yeah, really important. So, Tom, what did North Texas Medical Center do um, to get their hospital at home program started? What did you need to happen to make this a success?
Well, as Brian just stated, the platform was a huge piece of it.
Mhm.
It allows the clinical team to monitor and support the patients over multiple channels via telephone, text, video, and chat. And we needed the program to be easy to manage, easy to obtain reports from, easy for everyone to use. There's all sorts of components to it. It's not just the clinician out in the field with the patient. It's scheduling, it's staffing, documentation, and billing. So just having all that as a wrapped up in together in the same package was crucial for us.
And a little introduction for another conversation. When you look at hospital at home, many times people simply think of a inpatient hospital patient being cared for at home, but not different than any other hospital, especially in the rural markets. The predominant amount of care is being provided on an outpatient basis. So, really getting that conversation started early around it's hospital at home, yes, for an inpatient, but it's
Mhm.
also hospital at home for your traditional outpatient business as well. And building the infrastructure around delivering that care for that outpatient care is essential in making a program sustainable and successful as well.
Agreed.
Yeah, that's a really great point, especially as we're seeing more care move to outpatient settings. So, broadening it out beyond just the inpatient setting is a really good point. Thanks, Jim. So, Brian, can you tell me a little bit more about the hospital home services you've created?
Sure. So just like Jim was just speaking about, we looked at what are the needs of the community, what are the capabilities of the platform, and in partnership with North Texas and our partner Resilient, we created a unique program specifically for a rural community hospital setting. We started looking at, first of all, obviously inpatient at home services. That's what's really the focus of what we were looking to do was how do we facilitate access to care for patients in their home. Then we looked at outpatient services, right? Looking at therapies, occupational therapy, physical therapy, speech therapies. And then we also looked at primary care in the home and how could we provide primary care visits to patients in their home. So we stood up all of those care settings with the program first. And then we started looking at, okay, now what do we look at doing? right? Because once we have all of those things under our belt, we understand the process and the workflow and all of the things that go into that, then we start looking at what are other services that we need to evaluate. So how do we get into other areas that our community needs? And we looked at our community needs assessment and what is happening in that community today. And we started looking at remote patient monitoring services, chemotherapy services, and critical care services. So there's a few things that we're actually looking at into the future. When we look and talk with our partner about that, it ultimately comes down to how do we make sure we have all of the components that we need from a technology perspective, a process and workflow perspective, and then a care provider perspective. So our partnership with Resilient is critical in that because they provide the hardware, the software, the workflow that facilitates all of our care. They also spent many months talking about education and training about how do our providers understand this. As you can imagine, when you walk into a hospital setting and you say, okay, we're going to bring inpatient care to our patients in our community in their home, you get a lot of blank stares, as you know, a lot of people don't know what you're talking about. So we had to do a lot of education at so many different levels. The other thing is that the next question that comes out, especially in rural communities, is, well, are you going to use my staff to do this? Because they're already taxed and I'm already having challenges recruiting. And our partner brings all of those staffing relationships with them. So they facilitate in the community working with other providers and bringing in staffing so that they could facilitate all of that. And the other thing they do is not only provide the care from a clinical perspective, but all of those ancillary services you wouldn't really think about, right? You might think about sending a nurse or a physician to the home, but when you bring inpatient services to the home, you also have to bring pharmacy services, lab services, some imaging services, dietary services, and all the other supplies you may need. So having a partner that understands that, has done that, but also has a mindset of how do we do this in a small community setting is so critical. And ultimately, we're really looking at how do we provide that improved access? How do we drive patient satisfaction? As you can imagine, Tom can talk about it, but as you can imagine, patients are very happy about being in their home versus sitting in a hospital setting for a number of days getting, infusion therapy or something like that. It also, because of the fact that it's easier for patients and we can monitor them continuously 24/7 over, dozen plus different data elements, we see that patients are better able to manage their care plan, and it actually reduces our readmissions. So we're really excited about that, is that patients are staying on those care plans longer, better, and recovering quicker, which is fantastic, which again maintains high quality in a home care setting. And for rural communities, that's an incredible advantage that they can provide that we might see in a large city like Dallas or Houston or Miami, but bringing that to a community like Gainesville can be a game changer for that community's health overall.
Another comment on what Brian was saying is when you're contracting through Resilient Community for this type of product, you are contracting with other people to be providers of the care in the home setting. Now, it can be your own employees if you have the capacity to do that. But if you don't have the capacity and you need that to be put together, we bring that to the table. But it's important to note that these employees that are providing that care get credentialed through the hospital. They are actually a representative of the hospital, credentialed by the hospital to be providing that care under this joint venture structure. And another kind of a comment is how this has evolved is this has been around for a while, but it really took off during the pandemic. And it took off during the pandemic because you had large metropolitan areas having people try to be transferred in, and they didn't have the capacity. The hospitals were full. They were backed up in the emergency rooms. Well, had this been effectuated before then, a lot of those patients would have been able to be cared for in their homes, being fully monitored, cared for, make sure everything was being taken care of, and that would have been a relief valve on the system. Now, with the pandemic being mostly tied down now, we're not seeing that type of pressure, but we still see surge pressure where people are saying we don't have the capacity to take this. And if they have that other offering, when you offer a rural patient the opportunity, offer any patient, not a rural patient, when you offer any patient the opportunity to be cared for and monitored at home, and a provider is telling them that they feel confident in the quality of the delivery of care, they're going to choose that option. Almost always, when they say, "Would you like to go upstairs and be admitted? Would you like to be transferred 45 minutes down the road and be admitted? Or would
Mhm.
you like to be admitted at home where we're going to be able to adequately monitor you and take care of you?" That answer is usually an easy one for them.
Yes, totally agree.
Yes, definitely. Such great points. So, Tom, I would love to hear from you. Tell us a little bit more about the process of introducing hospital at home at North Texas Medical Center. Tom and Jim did a great job talking about what it's like for hospitals, but it would be great to hear your kind of real world experience with this.
We had to build a pro forma to make sure that the service was going to be financially viable for the hospital. As Jim alluded to, running a small, or not even a small, but a rural hospital is a strong burden for the team to make sure we just stay financially viable. So we went through the pro forma process to make sure that this was an option for us. From there, there are a lot of things to do, everything from credentialing providers and payers, building out your policy and procedures, making sure that your clinical workflows align with your hospital clinical workflows. We're very proud of the care we give here, and we want to make sure that same care is delivered at home. So when we're talking to our staff about implementing this program, we really had to get everyone on board and explaining the why. This is not glorified home health. This is truly inpatient or outpatient care or even primary care in the home setting. And it's a needed service. There are a lot of steps that you had to go through with getting providers and hospitalists and other clinicians on board. We had to go and get a CMS waiver and then a state waiver. So it might seem on the surface easy to set up, but when you have to make sure all of the steps for hospital at home integrate with the care delivery that you give in the hospital, you can't have any lapses in that. It all has to be seamless.
So, Tom, tell me a bit about the process of introducing hospital at home at North Texas Medical Center. How did you start? What was involved?
First, you have to get everyone on board. Explaining the why of why we're doing this is a huge piece of that. Making sure that the staff understands that we're not trying to cannibalize the inpatient business or cannibalize the outpatient business that's currently going to the building and risking their jobs. They have to truly understand that this is an expansion of the services we offer. It's out in the community. It's providing a service for someone that might not be able to make it to us for transportation reasons or whatever, or they just may prefer to have the care at home. So once we got past that concept, uh, and everyone understood that this is truly an expansion of our services, everyone was on board pretty quickly.
Can you talk about the elements that were involved from a regulatory standpoint? What were some of the things you had to do on that end?
Well, we had to get a CMS waiver and then a state approval. We had to go through the credentialing of the providers and the payers. We had to develop policy and procedure that aligned with the hospital policy and procedure. We had to create the clinical workflows. Everything had to line up with the service that we provide at the hospital. So when we have visits from our surveying bodies, they will look at these patients just as they would as a patient in the hospital. So we have to make sure that everything is in line with what we do here.
Another element that's important in that is, even though from a legal perspective, it's just a extension of your hospital license, and you're providing and you're billing for as if it was in the hospital or if it was in the hospital outpatient setting. But our partnership has taken the approach that we want to communicate with the payers. Say, look, we want you to know we're doing this because we believe it's a good thing to do for the patient. It's a good thing to do for quality of care. It's a good thing to do to prevent readmissions, get greater utilization from patient compliance. So we communicated with all of the payers. We are doing this, and we want to make sure that they're on board with it. Many payers at first are like, if it's under your license, do it. Some payers are saying, well, explain to us more what it looks like. So having that open dialogue with everyone on the front end is also very important.
Maria, I would agree. And I would say Tom undersells the amount of effort that he undertook. It's a lot of education and communication. I think that's critical at the beginning of this. And I think what's incredible about what Tom and the team did there is the expansiveness of the people that you had to involve, right? When you talk about, it's every aspect of your hospital that you need to engage with, communicate with, educate with. And Tom and team did a fantastic job making sure that they brought everybody along on that journey, because it definitely is a journey. It's not a let's have a 1 hour meeting and now everybody understands what we're doing. Go. It's over time. It takes a lot of time and energy and focus to bring it to fruition.
I agree. And honestly, going through this process has helped us refine our processes for starting up new programs and new services, or even just making changes in the hospital. So it's been a learning experience for us across the board, but it's also been good for the way that we do things in the future.
What for Tom? What has been the reaction from staff now that you've been doing the program for some time? What's been the buy-in? Kind of how have staff been reacting?
Well, the buy-in is when they see the patient that tells them, I couldn't make my therapy appointment now for the third time in a row, and I just can't get there. And they want to see that patient do better, to improve, to heal, and to get back where their goals were to get to. So now, when we can now support that same patient in their home and they make the progress, everybody understands that's our goal. We're here to provide the best care in whatever avenue it takes to get there. And adding hospital at home has allowed us to expand that, and our staff really understands and appreciates that now.
Yeah, totally makes sense. The proof is in the outcomes, right? So that's fantastic. So this question's for each of you, but I want to start with Tom. What are some of the lessons you've learned through this process?
Well, we just hit on it a lot. The team has to be prepared for the effort and the lift that we're about to go through to get this started. It's not just inside the four walls of the hospital. That's what we're used to. We have to expand outside of that and understand all the complications that uh, arise from delivering care in the patient's home.
Brian and then Jim, if you both could go
Sure,
too.
sure, sure. Yeah. So from my perspective, it was as we entered the relationship with Resilient, our mindset initially was we're going to do inpatient at home, right? That was where we started the conversation. What we found going through the process, and some of its education, some of its process, workflow, compliance, regulatory, and payers, was that inpatient probably takes the most work in terms of setting up and having all of the infrastructure and the process and people all aligned. So honestly, we started and said, well, outpatient therapy is the best way to get started. We can stand it up quickly. It increases some volumes at the hospital because you had patients that may live 20, 30 minutes from the hospital and decided they were going to go somewhere else, or they weren't going to, as Tom mentioned, they weren't going to be compliant with their care plan. And so now we can bring additional volume into the hospital. And like we said, the patients love it. They are so excited. Again, like Jim mentioned much earlier, like if you ask a patient, do you want to have physical, do you want to come into the hospital 30 minutes away 3 times a week, or would you like us to come to your house, whenever we schedule time? To a person, everybody says, yes, please come to my house. The other thing is that through our partnership, as we looked around in all the at all of the market players, we had to find a partner that understood small community hospitals and understand that market is different. I'm not saying they're not both extremely challenging markets. It's just, it's a different market and your economics are different. And we had to make sure that we had a technology platform that, again, was flexible and could operate on all these different things. I think that's a huge lesson learned for us, is the technology has to be drop dead simple. So when we walk into a patient's home, we're evaluating a lot of things. We're walking in and making sure, is it a safe environment for the patient to stay in? Can they get the care they need there? Do they have somebody that can check in on them while we're monitoring them if needed? All of those things. And we needed a partner that understood how to do that in a rural and community setting where people are driving quite a bit more to get to those patients. And that really was helpful to have Resilient, who's done it before, did it during the pandemic, and has worked with other rural community providers to stand up programs like this, not at this level, but had done that. Um, and and they have the support and the technology to be able to support our providers, right? To make it simple for our providers, simple for the administrative team, and that they had staffing support, because that was the number one question. Actually, like I said, number two question we got after what is hospital at home was, can can we make sure that we're there, if our staff can do it and we have that, but to have that flexibility to say we'll build a program that is just customized to you. We didn't have to fit it in to some cookie cutter. I think the other thing is the time it takes in that initial planning phase. We initially said, "Oh, we'll be up and running with all of it in, a month or two," and because of some of the compliance and the workflow and just bringing staff along, that took a little bit of time. At this point in time, we're break even. We'll get to profitability maybe, but our real goal was, can we provide these fantastic services for our patients and do all of those great things and providing access and getting better outcomes and driving patient satisfaction? And we'll get there. In a break even in a small market, what we've seen is that we need about 4 inpatients. We need probably 100 outpatient visits and probably 100 primary care visits to break even. And so the numbers aren't tremendous. And we think we can drive that volume in so many markets across the country. And that's I think what's been the lesson learned. How do we approach it? What do we need to do it? And then what do those outcomes need to be to make sure that, as Tom mentioned earlier, we drive to the results that we pro forma when we started the program?
My additional comments would be around looking at it from a company perspective. Now, we've been around for 27 years, and our focus is helping community hospitals be sustainable. We see this as moving along that continuum. We wanted to be an offering for people that are exploring this to be able to bring you a model and say, we know how to do this. We've gone through the pains, we've gone through the difficulties of understanding what it takes to make a successful program. And we want to be able to show them a program that is successful. That's what we're putting a lot of effort into the North Texas initiative. We want to show them the quality results. We want to show them the care results, the patient satisfaction results, the fact that it is profitable. No one wants to be in a business that they can't sustain it because it's not profitable. And we believe that we have that path because of how we've structured it and all of the elements that we're able to go out and show someone else how to do it. So our partnership with the Resilient Community Corporation is what we're using to go out and say, we can help you make this happen. And helping people make it happen, the complexity, one of the first steps is getting people past the idea that it's just an inpatient tool. Again, a lot of the metropolitan areas, that's where they started thinking about it because they didn't have capacity to care for the patient influx. But the reality is, just like any other hospital setting, the bulk of the business is going to be in the outpatient environment. Structuring the tools to be able to deliver that successfully, having the relationships, and then having the medical staff and the employees of the hospital understand, like Tom was saying earlier, this is not about cannibalizing off of your existing business. This is about a different delivery model to capture business that's going elsewhere. Many of those outpatients that had their total hip done at Tom's hospital that went on to having home health for hospital therapy were able to have that home health therapy. But then when they were no longer homebound, they weren't able to have that home health therapy anymore. And they were sent to a physical therapy outpatient location. Sometimes those people came back to the hospital. Sometimes they didn't. Sometimes they went to a retail space in another community. Sometimes they went and had the care done at somewhere that was the other direction. But they also, at the same time, many times they just didn't do it. They got the therapy as long as it was under the home health environment. Someone was there giving the delivery, but then they said, hey, you need to go to have the continued therapy in this setting. They just didn't do it. And that caused people to get readmitted. That caused people to have complications. And this is a vehicle that's going to cause those patients to get that care in the same location under a different structure. There'll still be an outpatient structure, but they won't be a hospital at home inpatient structure. They'll be a hospital at home outpatient structure. And that brings patients more involved in their care delivery and their ability to continue to do the things they need to do to get completely healed from the procedure that they had done.
Yeah. One thing, Jim, along those lines, you mentioned some of those other providers and care settings. One thing that was interesting is, as we were talking and building out this program, we heard that there was a provider in our market that really wanted to become an at-home primary care provider. had done that years ago through some studies with John Hopkins decades ago, and was really intrigued and actually, um, came to us and said, I'd really like to become an at-home primary care provider, which very quickly allowed us to expand into the primary care space more quickly than we would have, and volumes have jumped up. And again, that provider, the feedback is that provider is extremely happy and his patients are extremely happy when he comes to their house. They don't have to go to his office any longer. So another interesting thing to think about is, do you have providers as you're building out the program? Do you have providers in your market that may want to move to a model like that?
I was going to also ask Tom if he could comment on two aspects. One, your ER group. Your ER group conversation is going to be essential to success. And if you have a hospitalist program, your conversation with your hospitalist, whether or not they want to be part of it, or whether or not they don't want to be part of it. The ER group, whether or not they're going to be supportive and understand what it's necessary to make a successful program, because those are two important elements. And I know, Tom, you did a lot of work to make sure that was successful.
Correct, Jim. Within the emergency department, those physicians are more than likely going to be the first interaction with a patient who might be appropriate for the hospital at home inpatient service. And so they can determine if they meet the criteria for the services that can be offered through the hospital at home inpatient service. So they need to understand what it is to identify those patients. And then the hospitalist on the other side of that has to understand, why does this make sense for me to not have a patient come and sit in the hospital and have me take care of them? Why does it make sense for them to go home and be cared for at home? Well, in our situation, we're lucky enough and to experience a lot of growth, as I mentioned earlier. And there are some times when we're taxed, we're full, we can't take another patient, and with every bed's full. And the hospitalist service understands that, and they actually appreciate the fact that they can now help take care of those patients in the home setting, even if they're not the one that's directly doing it, that patient is getting care. And some models may choose to have their hospitalists that are in the building take care of those patients. In our situation, due to the growth that we've had and the amount of patients that each hospital is taking on, they elected to have another provider associated with Resilient take on that inpatient care at home hospitalist service. One other thing to mention, not just the ED and the hospitalist providers, we also really wanted to make sure that we didn't cause any conflict with our local providers who are independent. We receive a lot of ancillary referrals from those from those providers. We wanted to make sure that they understood we weren't out there trying to take their patients from them with the primary care at home. This was just another avenue that we could provide a service to someone that might not get the care that they needed. And once we explained that, they were very happy and understood what the program was for, and that this was good for them and their patients as well.
Maria, I was just going to mention something that Tom said I think is very important for people to hear, that all of the decision-making process about whether a patient qualifies this is all made by the clinical care team first, right? So when somebody's in the emergency room, they're not looking to qualify them for hospital at home. They're looking to qualify them. Does this patient need inpatient services first? That determination is made prior to anything happening around hospital at home. And so once that inpatient admission is determined by the care team in the ED, then there's a conversation about whether or not that patient meets this criteria for hospital at home services. If that's determined that they could, then there's a conversation with the patient. Do they want it? We also need to understand the environmental situation that they're in. Do they have all of the capabilities that they need to be able to have that care at home? So it's a multi-stage process that we go through, but it starts with the clinical team and making a decision about what that patient needs. And then we look at it and see. We have markets that we've talked to about this service. Interestingly enough, like when we're looking at environmentals, we have to be concerned about so many things in rural communities you might not even think about. But I was talking with a CEO in Colorado about a program like this, and he said we have many of our patients may not have running water or electricity. Right. They're ranchers that live out in very remote areas. And so we have to think about all of those things, not just can we provide the care at home. And then when we go into the home, the first thing that happens, an APP comes in and sets up the technology and then evaluates that environment to make sure that it's it's safe for everybody and that it's the right place for the care that needs to be provided.
Yeah, such great insights into all that goes into hospital at home, but also why it can be so beneficial for patients. So thank you for all of those comments. To wrap up, since we're at the end of our time together, I wanted to just close out and hear just final best practices for hospital at home implementation. We'll start with you, Tom, but Brian, Jim, if you have anything else to add on too.
We've talked about it a few times, but understanding the program, what it offers, and not just hospital at home, but understanding the different implementation requirements for each of the hospital at home services. We really try to break it down. Every time we have a meeting, whether that's through virtual meeting or in person, when somebody speaks about one of the services, I was pretty insistent that you identify it as hospital at home inpatient, hospital at home outpatient, or hospital at home primary care, because each of the services have such different set of requirements that we really needed to be on board with what service we were talking about at each time, because when you're rolling out multiple implementations, you've got to make sure that you're doing and talking about the right service when you're thinking you're talking about that service. It was pretty confusing early on until we got to that methodology of describing each and every service independently. I would say educating and engaging the providers. We've talked about that, making sure the medical staff understood what was involved, getting all the payer credentialing done and the physician and provider credentialing done. I would say over communication and inclusion is key. You can't say it enough. Over communicate. If you think you might be leaving someone out, you probably are. I would say making sure that that communication goes inside and outside the hospital to make sure that you have strategic alignment from both areas. That's not just your hospital has to understand it and your hospital staff has to understand it, but the folks we're working with at Resilient, they understand. Maybe they're not as used to some of the hospital requirements that we deal with on a daily basis. So making sure we fully explain why those requirements are in place and why we have to achieve them before we can move forward. I think those are probably some of the biggest things that we had to make sure that were done.
And I would also add, I think the reason we've done this as a company is we want to be able to be a resource to communicate how to best practice make this happen. And in doing that, we believe that we have put together the tools that can help a hospital look at this, explore it, understand what it's going to take, and the successful steps necessary to make it a successful program. And there's a lot of companies that out there that are saying they're doing this, but they're just the technology side. They're bringing you the tool to be able to do something. It's almost like saying you're bringing someone an EMR. An EMR is essential in having a good program, but you have to have the infrastructure to properly utilize that EMR to be able to deliver care safely and effectively. And that's why we package this, and we'd be happy to help anyone that's out there wanting to explore this. And I think we can show you the path to get there as quickly as possible and as successful as possible.
Fantastic. Well, thank you all so much for your time, Tom, Jim, Brian. This was great. And to our audience, please enjoy the rest of the event. Thank you to our speakers for that great discussion. We'd like to once again thank the sponsor, Community Hospital Corporation. For more information about them, please visit chc.com. Thank you to our audience, and please enjoy the rest of the event.